And now I have the pleasure of introducing Dr. Ali Husain.
Well, thanks very much for having me. It's a real pleasure and an honor to be speaking at GlomCon, which is a series I think is very, very important. And then speaking about a topic that's very personally important to me as well. And I know there are some people from in the U.S., outside the U.S. We have some trainees and faculty. So hopefully this is kind of interesting to all of you as I present it. To start out with, I have no relevant conflicts of interest to disclose. What we'll cover is a few things. We'll talk about why you should care about access to transplant in the US, what racial disparities that we know exist in access to weightlifting and the transplant in the United States. We'll then talk a little bit about what I think and what others think about what leads to these disparities in transplant access. And finally, we'll end by talking about some potential policy solutions to improving equity and access to transplant. And kind of the objective of today's talk is really to focus on that last two bullets. So to start with, why should you care about this in the first place? So as everyone in this call probably already knows, the incidence of ESRD and CKD is rising throughout the entire world. I'll focus in the US for the moment, but you can see here on the left of your screen that right now there are almost 140,000 incident ESRD cases in the US annually. On the right side of your screen, you can see that it's a highly prevalent disease no matter where you are. Certainly there are hot spots like the geographic Southeast or the stroke belt where there's a lot of ESRD, but there's really no part of the country in which there's very little ESRD. Unfortunately for that growing number of people who have ESRD, the prognosis of kidney failure is pretty terrible. Here on the left of your screen, you can see that whether you're doing hemodialysis or peritoneal dialysis, your 5-year mortality after starting dialysis is more than 50%. In other words, you are more likely to be dead than alive 5 years after starting dialysis. And on the right side of your screen, you can see that that's actually pretty bad compared to other diseases that we care a lot about in terms of improving access to care, in terms of funding research, and in terms of just generally doing public advocacy. And so really there's a mismatch here. And what's worse is that these poor outcomes come at a very high cost to the healthcare system. You can see here, this is annual ESRD spending as a portion of total Medicare spending. So if you think about how many millions of people in the US are on Medicare, 7% of the entire Medicare budget is spent on ESRD. That's a number that in 2021 was up to over $50 billion per year. It's like kind of a massive number to think about it. So you're having these really bad outcomes at a very high cost. And so optimizing ESRD care is necessary to both improve the health of the patients who have it and also improve costs. And really that comes down to kind of pushing good treatment options. And thankfully we have a really good treatment option for ESRD, which is kidney transplant. And kind of your number one message in this first part of the talk should be that kidney transplant is better than dialysis in basically every single way. So starting to talk about survival first, you see here that throughout every era in which the data is collected, transplant is associated with a much better survival compared to any form of dialysis. You can see here more than twice the likelihood of survival at 5 years. If we look at this at a per person or per 1,000 person years perspective, beyond just 5 years, you can see that the mortality with transplant compared to any form of dialysis is about a third. So you're cutting the mortality rate by 2/3. And just so you don't think this is an artifact that I'm showing you of the fact that many old people never get a transplant and they die on dialysis, here's an example of using the shared decision-making tool about dialysis versus transplant of a younger individual. So a 24-year-old woman just started dialysis less than 6 months ago. Her mortality benefit is also massive, even though the absolute numbers of death are smaller. You can see here, she gets a living donor transplant, her three-year mortality goes from 23% to 1%. Really a massive reduction. That survival comes with an improvement in quality of life in pretty much every quality of life domain that we know how to assess. We're talking about everything from cognitive function to sexual function, how much physical pain you're in, your emotional well-being and social function. And that's better with transplant compared to either PD or HD. And what's even better is that it comes at a net cost savings. So the annual cost per person of transplant compared to dialysis is at least a 50% reduction when you're thinking about PD or HD. And even if you consider the fact that patients on dialysis are more likely to die, so their cost kind of ends at their death. If you look at an average patient over 10 years where the transplant compared to dialysis, you're saving sometimes more than $100,000 per person, depending on the type of transplant that's performed. So clearly an optimal treatment. And what's even further important is that earlier transplant is better than later transplant. So here's data from the Austrian Kidney Transplant Registry, just under 7,000 first-time kidney transplant recipients. You can see that top line is patients who had no pre-transplant dialysis exposure, The red line is the lowest tertile of dialysis exposure before transplant. You can see that post-transplant mortality is actually impacted by your pre-transplant dialysis time. And the less pre-transplant dialysis time you have, the better you do in terms of mortality after transplant. Even further, evidence for this is that even if you take a really advantaged group of people, so this is living donor transplant recipients, who should do very well overall, among these living donor transplant recipients, their mortality is reduced by 26% if they get a preemptive transplant compared to a transplant after initiating dialysis. And so that's a lot of information in a short amount of time, but your take home should be of that transplant is just better than dialysis, period, in every way. And earlier transplant is better than later transplant, which should then make you very upset to see that only a minority of ESRD patients are ever even waitlisted for a transplant. And this proportion is actually going down. So you can see that even before COVID, which certainly impacted waitlisting and ESRD mortality,